The sampling bias, because of the different profile, I think will be statistically adjusted, so it's not a problem. The question is about the non-response rate. During the household listing, we had non-responses of 33% at baseline and 22%. These were the households where girls were at school, so they were not present, maybe in boarding school, so you couldn't reach them at all, or where the parents of the girls themselves did not want to tell the enumerators if they had sex, agreed to be intimate. Conservatively, we estimate that these girls that refused or they were not present had the same sexual behavior as the ones who answered the question. So it means about 50% had sex and would therefore count as non-respondents in the survey. And this decreased the actual non-response rate to about 16–17% in the baseline and to below 10% or about 10% at the end line, which is not really unusual. Among the girls who were listed, no response was found 8 or 9% in the two surveys, which again is not unusual and quite accepted. So then we had some additional findings that are interesting. I'm not presenting all of them, I'm just presenting some key additional findings. When we, again, when I talked about the couple-year protection model, I mentioned that using the assumption that 40% of women who did not use contraception would fall pregnant. This assumption does not necessarily apply to adolescents. And you can see, for instance, here among the young girls, and this is, I don't know if you see my pointer here, 83% of those who said that they had sex, it means they were ever sexually active, did not actually have sex intercourse within the past month. And this will certainly affect their contraceptive choices. If a girl only had one intercourse once or twice in their lives, and possibly even coerced intercourse, then the more appropriate contraceptive choice in that case would probably be emergency contraception, and certainly male condoms would be much more appropriate for those girls who have sexual intercourse rarely or once a year, rather than oral contraceptive for the whole period. It's obviously different among older girls and girls in partnership, where we see the 19-year-olds in partnership, 65% of those who had ever been sexually active also were currently sexually active. The main source of information about contraception, we have presented this in the graph for friends and followed by schools. Health facilities come only in third place. And among the choices of contraceptives, male condoms were the most frequently used methods. Both at baseline and end line, implants increased in that period, and injectables decreased as choices. We asked the girls where they obtained their contraceptives, and overall, most of them obtained their contraceptives from public health facilities. Public health facilities in blue here are the most important providers of contraceptives. Of course, there is a change with age. Young girls tend to go more to pharmacies, and as they get older, they switch to public health facilities. The assumption we have here is that these girls mostly use condoms, and condoms are just as easy to get in a pharmacy than to go to a health facility. Private health facilities play a role, but not to that to a major degree, and faith-based health facilities were not practically used at all. Then we asked these girls how they paid for the contraceptives. And we found that the youngest girls most of them tend to pay the full price. Again, maybe related to the fact that they mostly went to pharmacies, and maybe related to the fact that they used condoms, which were being sold to reasonable prices in pharmacies. As they get older, they get more and more free contraceptives, and they clearly stated these contraceptives are always provided free of charge. Again, this likely also related to the fact that as they get older, they move to in fact provided free of charge. Then we asked whether they used a card or an app to obtain a discount. We were actually not aware at the time that there was no such thing as a TICO app. We had assumed there was, because we had initially had a discussion with Turquoise about face recognition software, and figured this could only be done if there was an application. But apparently there was no TICO app, but we didn't ask specifically about a TICO app, and then maybe other programs that provided a discount or free services. Very, very few girls actually used any of these means to get discounted or free services in private clinics or pharmacies. And among those who did, we asked specifically, only half of them actually referred to TICO. At the baseline survey, when we did the baseline survey, we asked the question, maybe quite naively, are you registered with TICO? And only 6% of the girls stated that they were registered with TICO, which surprised us, and we discussed it with Turquoise. And a number of hypotheses were generated. Either they didn't understand the question, or the name of the platform had changed at one point from T-Safe to TICO. There were other hypotheses. So we expanded the questioning in the advanced survey. We asked them, first of all, have you ever heard about TICO?
Very good.
Hello? Have you ever heard about TICO? And actually, 1 in 6 girls stated that they had heard about TICO, more among the older girls than among the younger girls, which is, quite a good result, except if you think that we are trying to target at areas where the most intensive activities of the DIP project were taking place. So we would have actually expected more. But however, only 224 girls, only 4% had enrolled. Among those, and only 182, even less, had participated in the community event, and even less had received any SMS or WhatsApp messages from TICO. So this is actually a very surprising finding for us, and we cannot fully explain it. So to come to the conclusions, the pre-post survey confirmed an increase in adolescent modern contraceptive prevalence rate in the survey area of 2.3% within 8 months. Actually, that's really quite impressive. If you expand this, if you think this is maybe a linear increase and you take it to maybe over 6 years, it would mean a 20% increase, which would be quite impressive. We actually didn't think that within 8 months we could show any increase at all. Since there was no random sampling, we couldn't use any statistical methods to infer on a larger population. There's some questions there. But we believe that by purpose of sampling, we achieved a coverage of 50% of all areas where the project had delivered services. And therefore we assume that the survey population is representatives of adolescents in the project areas. Comparable data don't exist, and this was kind of expected, but you are probably going to receive data from the KDHS, which I think is ongoing right now. You get it by next year maybe, and you could look at the slope of the change in CPR between the 2014 and 2022 KDHS, and assuming that it is a linear slope, linear progression, you could look at or superimpose the 8-month change that is documented in the survey. Maybe it will show that there is some attribution. Again, I mentioned the low level of registration in TICO is a surprising finding which we cannot explain. Thank you very much, and we welcome questions.
Thank you. Thank you, Joseph. And I believe we can see how everything has come together from the point of when the negotiations started between the three main partners, bringing on the third-party monitor, as was acknowledged in a COVID season. And also, you can also see some of the challenges even the data collectors actually had on the ground, where even trying to interview girls during COVID lockdowns, and of course, getting parental consent. So we are happy with those findings of the 2.3% NCPR. And as was alluded earlier, we did have to sit down and have a renegotiation on the outcome payments because working in that context was also quite difficult, as most of us know. And as Richard had talked earlier, the benefits of also having the DIN is that it's a partnership, so you can always go back and renegotiate terms. And there's always that routine aspect of where you look at the results and you assess, people review, and then you continue. So we are now at 1 o'clock, and we wanted to take a few more questions. I want to probably hand over to Doc as you highlight some questions on the chat, and then we open to the floor. Thank you.
Thanks, Akacho. There's a question from the chat from Boyd Brenda from the Reproductive Health Network of Kenya. And this question reads, did the project find or document any challenges on consent, right to access, and provider provision barriers, for example, policy barriers of threats or arrest for providing services to adolescents? If yes, what was the project's recommendations?
Okay, I think let me take one more from the room, and then Joseph can answer.
Good afternoon, everyone. Thank you so much for the presentation. My name is Tabi from DESIP and AVSO. My question is in regards to Richard mentioning that there were persons we had targeted persons with disability. So maybe just to understand how many people you were able to reach out of the 5,862 girls who had disability, and maybe some of the strategies that you used in terms of reaching the adolescents with disability, and particularly those with intellectual disability. Thank you.
Okay, is yours related to Hera?
Yes.
Okay, just one more for Hera.
Thank you. My name is Kenneth Macharia, country representative for Options. Thank you for the presentation. My question is that, actually comment first, is that this is a really good piece of work, and it's meant to be catalytic. The one question I'm left with is, what next? And the question is regarding, was there recommendations on what should happen going forward? Or are we going to have a constant rolling out of bonds? So I'm just wondering the connection with local financing and all the rest. Thank you.
Thank you, Kenneth. So I think let's just start with those few ones, and then we'll do another round. Over to Joseph.
The question on, first of all, I have to emphasize that this was not an evaluation. We were simply asked to verify the payment indicators. So, you know, the number of recommendations we can get, the number of detail is not the same as if we had been charged with the evaluation itself. And I think this is very important. Provided barriers, it's interesting that this question is asked. You know, when we did the data verification or the data quality audits, the two data quality audits, we compared facility registers with data on the Triggerized database, and we found at least one facility where no girls had been registered, entered in the register, no underage girls had been entered in the registers. And although there had been made claims to Triggerize, it was this raised a flag. And after asking some more and investigating it, it was that the providers were afraid to report the provision of contraceptives to underage girls to the government. So they simply did not put them into the register. This was actually the only instance, the only time that we noted that there was an issue there. Otherwise, we did not further explore this issue. On the issue of disability, again, this was not an evaluation. We were simply asked to verify the indicator, and we did not record how many girls that were interviewed had any kind of disability. I think it's a different kind of study that you need for that. There was the question from options. Yes, I mean, again, you know, what recommendations do we have? We actually, from the type of work that we did, we can only make one recommendation, and that is when you design a development impact bond and you have specific payment metrics, make sure you have sufficient budget in the bond to measure those payment metrics, because this was, in fact, one of our main constraints, that we actually had to keep modifying designs, approaches, because, you know, we had this budget limitation, and that just doesn't work. Because, I mean, this system really depends on exact measurement, otherwise, yes, it does not get paid. So, you know, this is really our main recommendation for this exercise.
Thank you. Any more?
There's another question from the chat from Julia Greenland from SIF. This question is addressed to FCDO. The question reads, when impact bonds are done in the UK for social services, there isn't an external verification exercise, but payments are made on routine data collection only. What is your reflection from this experience on the value versus the cost of external verification? Is it clear, or should I just repeat? Okay, it's clear. Let me repeat one last time. When impact bonds are done in the UK for social services, there isn't an external verification exercise, but payments are made on routine data collection only. What's your reflection from this experience on the value versus the cost of external verification?
Thank you for that comment. And I think, as we alluded to earlier, this has really been a lesson for everybody. This was the first time that the Kenya office has funded a development impact bond. And we do also have our colleagues in the UK office. And as Dr. Samora said, we had the village enterprise bond that we also borrowed from the one that was in Uganda and Kenya. However, this one was unique in the sense of course, having to negotiate all partners, having to ensure that we're all on the same terms. I think what we also didn't mention was that originally the payment metrics were on 80% service delivery and 20% on the MTPR target. And so when we also realized that Triggerize was overachieving the service delivery, we had to now also reevaluate, was the MCPR really ideal? And to your question, yes, it is quite important. I think to have an objective, do I say an eye or monitor, because it's important, because obviously as the fathers, we are often limited. We can't be on the ground, we can't always be there. Obviously, I think for SIFU and the investor, we do appreciate that it took, I think, much more time and effort than everyone anticipated. However, the good thing about it also is that through it all, I believe we all learn from this experience. And this is also to inform the UN team even as they move forward. It's important to obviously have a monitoring aspect. And I think lastly also to say that there have also been DIBs that have not achieved the targets that have also been funded. So just to say that this is a DIB does not mean that all the outcome targets have to be achieved. So I'll also hand over to Samora to comment.
Thanks, Akacho. Thanks, Julia, for that very good question. I think just to add on what Akacho has said, one of the challenges that has been mentioned here is because of the nature of the program, we really didn't have sort of the routine data that will help us inform sort of that assessment that you're saying. You know, we're talking about adolescent girls. They're not necessarily a group that you can go to KDHIS and see how you can get that information. As Richard pointed out, some of the service providers or pharmacies that are not necessarily part of your regular sort of data points for KHIS, as it were. So I think that was one of the challenges, and that's why it was important for us to have a separate evaluation process to do this. Does it represent value for money? I think yes, it does. If anything else, it gives us that confidence. Given the challenges that I've mentioned about lack of data, I think you needed that confidence that actually there's value in this. But as I talk about that, I think the other thing that is worth pointing out, some of the challenges that we've seen with this, and I think Joseph mentioned this a bit, was the timeline. With these kind of things, what you generally see is it takes a lot of time. It takes a long time for you to feel the impact. As has been mentioned, in ours was about 18 months of programming, and we had to include the sort of baseline and endline study. So the baseline wasn't exactly baseline because I think it came in 3 months after the program had already begun, and then we had to start doing the endline in time so that it ends by the 18 months. So there's a question about was really that enough time for us to assess the impact. But we felt that that notwithstanding, we could actually infer some impact on this, and especially through modeling. So there are some challenges there that as the UN team is looking at taking this forward, I think it's just important for you to reflect on, give yourself a bit longer time to allow that impact to actually be felt. And if possible, when you talk about sustainability, a question we've been talking now, it's not just because we are doing this program and then we want to test if it's impact now. I think sometimes we want to give ourselves a bit of time to see, does that impact actually hold a few years after the program? So I think in the benefit of hindsight, we could have done a few things differently from a design perspective. Just something that's worth thinking about as we take this forward. Thank you.
Thank you. Any more online before we do another round? Okay. So yeah, let's just start with that. Then we come to Dr. Koro.
Susan Ontieri from PSI, and I would like to really congratulate the team for the good work. And as Dr. Samora has mentioned, when you even look at these findings, considering that the baseline was not a true baseline, most probably even the net effect was much higher than what has been observed. My question goes to Hera on the last comment where they indicated the low level of registration. Did we try to correlate with mobile ownership? We are looking basically at the age 15 to 19 years. The primary model is using TICO, which is delivered through a mobile phone. Could the low registration be also attributed to most adolescents that age do not have access to a mobile phone? And then the other thing about the data collection, did we control the fact that some of the data, I think, was it the baseline or the endline, was collected during a school holidays compared to the other period? Because then it means it was not really comparable.
We'll take 2 more questions. Dr. Koro, then next.
Thanks a lot to the team once again, and mine is also related to what Susan has already alluded to, and more specifically is given that TICO is one of, as we roll out, go on to this, we want to leverage on TICO, and the enrollment was low, and that did it have an impact, and what are the other factors that accelerated the success that we could actually leverage on moving on, because I believe it will be more sustainable, if at all, especially when it's not financial in nature, so that even at the counter, the facilities will take up. And lastly, I know this, Joseph already said that this is not an evaluation per se, but could there be any other confounding factors for the success that we maybe also want to look at? Thank you.
Thank you. We have one more question.
Thank you very much. My name is Kennedy from the Ministry of Health. Thank you for the presentations. From the presentations, what is coming out clearly is that maybe just to all of us, that even as we design programs, we need to have the end game. And the end game is what will help us ask this question: for how long should our programs last to be able to have an impact that then can inform policy? Because from the second presentation, we are in a situation where we are not sure if those findings can then inform policy for this particular age group. Thank you.
Thank you. Over to Joseph.
Yes. Okay, well, thank you very much for these questions. The first question about the level of registration in TICO and mobile phones. Well, TriggerWise actually has three methods of registering. They are called high-tech, medium-tech, and low-tech. The high-tech option actually requires a smartphone, and it's basically used, I think, by 24 girls that we did the last verification. But the majority actually used the so-called low-tech form, which means they had a card. They did not actually need a phone, not even a non-smartphone. So the registration covers registration by card or registration by SMS in this survey. Yeah, the other factors of success, I mean, we have to acknowledge that at least among this population, most girls use public health facilities. Many of them, most of the contraceptive most used were male condoms, and neither public health facilities nor male condoms were included in the TICO project. There may have been some, outside benefits from the mobilization that TICO did, but we actually could not find any evidence that would tell us firmly that this increase in contraceptive prevalence is related to the DIP project. It is an increase in, enormous increase in adolescent contraceptive prevalence over a short period of time. What other factors may have driven it, we cannot tell, but we have to also note that it was primarily among older girls and among older girls in partnership. So it is very possible that just the standard approach of the Ministry of Health of Kenya to promote contraceptions not among young adolescents, but among 19-year-olds who are married, had actually contributed to this result as well. The last question was about the short duration. I just wrote down 18 months. I mean, this is again, I don't think you should do this type of monitoring or testing over such short time periods, and anything gets cut down to even more, to 8 months, it becomes highly questionable. So, I think Samora mentioned that before, if you are thinking about another type of approach like this, plan it over a longer period of time. It's not so much, not even to measure impact, but just to measure outcome, because contraceptive prevalence rate is an outcome, it's not the impact. The impact is actually the adolescent pregnancy rate. And that would require another much more profound study to actually measure that difference. So, my suggestion is, I support the suggestion to think about these things over a longer time frame. Maybe I didn't completely capture that last question.
You'd like us to repeat? Oh. All right. Okay. They're saying it's a statement. I think, I'm also being told the time is tight, so we are also available. You can contact us after the meeting, and I think you can also put our contacts in the chat for anybody else with questions. However, we do appreciate the comments that we've got, and like we had said earlier, this is all a lesson learning for all of us, and including also our UN colleagues. And we're just happy that this is a partnership that has started, and that also that the Ministry of Health is a key partner in the next phase of the Development Impact Bond. So without further ado, I'd also like to welcome DG Amok, just to give his reflections before we close and move for lunch. Thank you.
But I'm loud enough I don't have to do that. Okay, yes. That tells you I was born before that period. Thank you once again, Natasha and team, for destination of these important findings. Again, from the presentations, from the data that have been shared, figures don't lie. Our adolescents are sexually active at a much younger age. They get more information from friends, information which may not be factual. So I think the work that Dr. Estella and team did at the division of launching understanding adolescents, because the next source of information in schools is critical. I don't know how we can be able to bring the teachers on our side so that they become the custodians of that book, so that within the framework of ongoing classwork, we can be able to set aside time so that we can be able to dig deep into that book so that they can be able to get the correct information. Not surprising that condom is the most frequently used contraceptive method. Again, good for prevention of sexually transmitted infections, including HIV. But again, the risk of pregnancy is very, very high because of the high failure rate of private infection. So again, as a ministry, we need to go back to the drawing board to see how we can ensure that we use the more modern methods to ensure that even as they use condom, which is now a dual method, then they're also protected from the pregnancies. And it is good to learn that they are accessing the services from public health facilities, 50%. But that means half the population is not served by public health facilities. Again, we also need, in terms of policy imperative, to be able to see pharmacists are playing a critical role in provision of these services. How do we harness that resource of the pharmacists and the chemists around? And then how do we create a portal for them so that we can also be able to capture that data for policy formulation? This again proves very well misconception that has been there before. Before they said no developing country can be able to increase MCPR by 10% within a period of 5 years. Kenya did it, and I remember we were awarded a prize in Indonesia. Look at a short period of time and look at the impressive results of almost 3% CPR increase. Okay, we are going to compare that with the KDHS data that we are collecting for 2022. And it shows that innovative financing mechanisms actually work for healthcare interventions. But I need this data to be shared with the counties so that counties within their own resources can be able to prioritize and also look at these different financing mechanisms to see which will be able to work for their population. I want to congratulate FCO, SIF, all the implementing partners for this data that has come from this study. I think for us, we need to be able to look deeply into it, Dr. Estella and team, so that we can be able to develop the necessary policy directions for this. With that, I thank you all for participating, and we look forward to seeing how we can be able to scale this up in the near future. Asante.
Thank you, Bwana DG, for the reflections. And we also do appreciate the support we've been getting from the Ministry of Health and also from NCPD and our other partners in the government. So we also say thank you to you. And as we close, I'd like to call upon the CEO for PS Kenya, Joyce Bandiari, and then Dr. Iguru will close for us with the prayer. Thank you.
Thank you, Akacho. Thanks everyone for participating. Thank you, Bonadiji, for actually coming and staying with us up to this point. We really appreciate it. I think that's a very good testament of the collaboration and the partnership we have, which is really appreciated. Thank you for the development partners in the room and online. We really appreciate as well. Our implementing partners in the room. I can see quite a number of them, of course, and also online. You must agree with me, it was a great learning session. And I think also a beginning of conversation. I think in the period of policy reviews, guidelines development, strategy, so all these sharing sessions that we are having are very important for us to be able to inform how we move forward. I think it was very clear that without repeating, that youth is pillar of the development and future of this country. So we must work hard to make sure that we are addressing the big challenge. And I think it's very clear it's resolvable. It's just a question of how we collaborate, all of us to be able to do that. I took out one interesting thing around segmentation of youth and adolescents, of course, because you can tell like youth in partnerships are actually more, we had more increase in youth in partnership than younger youth. So a question of how we respond in terms of strategies to the different cohorts of the population, of the youth population. Innovation is the way to go, you must agree with me. In terms of implementation, and in terms of course, financing, resource-based financing. We've seen some evidence, we've seen others. Our DESI program actually has a part that is performance-based. We only unlock it when we hit our CYP target. So I think increasingly we are seeing a lot of lessons, even from Kenya, with this and other countries as well, on how important it is to innovate in terms of resource-based financing. So very important for that innovation, but also in implementation. Young people, obviously, we have to be creative on how we implement. It's not what we did yesterday will not get us there. I think even as Dr. G was talking about the DHS coming out, one thing also that we have to appreciate is that we've made so much progress as a country, but the truth is also we've also sort of like touched on the low-hanging fruit. So the next stage is going to be tougher for us, so we have to be more innovative in how we do this. And lastly, for me, and as has been said also by the DG and others, just an enabling policy environment that allows us to do the work, bridging the gap between policy and practice, because you've seen the practice follows the need, you've seen what the program is doing and others are doing. So how do we make sure we enable the practice by ensuring that we have very good policy environment that actually helps us to follow the need? And I think we are, in the room, we are all converted, we are the missionaries. So we have to make sure that we convert others. So thank you very much. With no further ado, I just have to say, make those few statements. But for me, it's to thank everybody for the support so far and the collaboration. Let's keep working together. Well, it's very important for all. Thank you.
Thank you for
thank you for these wonderful presentations. And to echo the words of the Director General for Health, we're looking forward to working together in the future regarding these concerns and our adolescents. I had several questions, but I think I will save that for the meeting which we can schedule to discuss this matter further. Thank you so much. Would you mind to stand so that you can pray? Let's pray. Our kind and loving Father, we thank you for this wonderful day. Oh God, we get to see work that has been done, efforts that have been put towards bettering the lives of adolescents. Jehovah, my Master, we thank you for even the evidence that has been collected thus far. We thank you for the lessons that we learn. We thank you for giving us the responsibility for our nation, Kenya. And so we bring before you our concerns. And we pray, Jehovah Lord, that you would be able to give us wisdom to address these concerns to the glory and honor of your holy and matchless name. Bless these that are planned for this meeting and even for future collaborations and partnerships. Bless the leadership of this country, and we thank you for all your provisions. We pray for all this in Jesus' name. Amen.
Thank you.